Good afternoon. My name is Paulo Villus. I talk about therapeutic hypothermia after in-hospital cardiac arrest in children. Start with definition. Therapeutic hypothermia is recommended for comatose adults after witnessed out of hospital cardiac arrest, but data about this intervention in children are limited.
Mortality rate, and it's due to a variety of reasons. The brain starts to undergo a degeneration, basically a self-destruction, where certain chemical processes start to take place, which accelerate cell death. From the time of arrest to the time you reestablish that circulation is what determines your survivability. By starting hypothermia, by reducing the body's core temperature, you actually stop the internal injury process that takes place on a chemical basis. How you institute hypothermia can vary. The main goal is to try to drop that temperature down to about 32 degrees Celsius within about 3 to 6 hours of the time of the arrest. That's your magic window of achieving that hypothermia. You happen to be picked up by an ambulance, placed into the high circulation areas, the axilla, the underarms, the groins, even around the head. Once you're in the hospital, we have some devices that are more formal or sophisticated in cooling blankets, and then another device that's actually inserted into the main vein of the abdomen that exchanges heat internally very aggressively. So we will also institute other sedative drugs to which is a natural response, but that consumes oxygen, so you don't want that taking place. So in addition to the natural coma that the patient's in, the drugs will help blunt any feeling of discomfort or, that you're actually cold. Therapeutic hypothermia has not been widely adopted. It's one of these unusual therapies that's been around and accepted for almost a decade, but has been slow to evolve into common practice. And it's one of the things that we're dealing with from a medical education standpoint, is to get this therapy out to the public and get it instituted in a timely manner.
Application in nursing. We conduct this trial of two targeted temperature interventions at 38 children's hospitals involving children who remain unconscious after out-of-hospital cardiac arrest.
Hi, my name is Marianne. I've been asked to do a demonstration on hypothermia therapy. So the first thing that we want to do is find the machine. And the reason that we do hypothermic therapy is post-cardiac arrest. There's been better outcomes resulting from it. So, here, okay, turn the machine on. All right? While you're turning the machine on and you're warming up, you fill the reservoir with a gallon of distilled water. All right, you just pour it in. There's a little reservoir note in there, and there's some water in there. So you don't want to overfill it, because if you overfill it, it becomes a huge mess on the floor, and you're in an emergency situation. You really don't want that mess. So that's go. Secondly, what we want to do is get the probe. There's a rectal probe and a Foley probe. And the reason is because we need to check the patient's temperature. There's also an adapter. This adapter plugs into the upper right side, and you're trying to check the patient's temperature. There's also a Foley probe, okay? Now, the most important thing with the Foley probe is not to only just plug it in, but get a Foley catheter set up on manual. You set to 33 to 35 degrees. That's the optimum temperature that you get out of the bag. You attach it to the machine again, the blanket, and secure it. Now, what's going to happen is you open up all the connections, Make sure they're open so that the water goes through the blankets. Could you help me? Sure. Because you're not letting the patient touch the chilled blankets. And remember, one over here, please. Get on the other side and roll that over. Thank you. Into the blanket. Okay, and roll the temperature of the patient. The second blanket. To the second connection. So essentially, you've reached the optimum temperature of 30. The quicker you chill the patient, the better the outcome. And one more important thing is that this machine is going with the patient to the unit. So make sure when you're taking the patient, you have someone to take the machine and you unplug it.
Issue in Ecuador. The groups had similar incidents on infection and serious arrhythmias, as well as a similar use of blood products and 28-day mortality. Video 3.
You typically bundle up to avoid hypothermia, but hypothermia is actually helping save some lives. The chances of surviving cardiac arrest are slim. 9 out of 10 patients whose hearts are restarted end up dying in the hospital. Anna Jackson gets answers on how inducing hypothermia increases the odds of survival.
Playing outside with her kids is something Mary McMichael-Liston will never take for granted after a health scare a few months ago.
As I'm told, had been downstairs watching a movie, just relaxing, and decided to go upstairs and take a bath.
I called her name several times and got no response, and then saw her do what appeared to be a gasping of breath that I realized something was wrong.
Mary was suffering cardiac arrest. Medics and doctors at Riverside Methodist Hospital saved her by inducing hypothermia.
The damage that usually occurs when there's lack of oxygen.
Hypothermia slows down the process. With this blanket, patients are kept in a hypothermic state for 24 hours. A machine pumps water.
Induced comas, hypothermia, that is just astounding to me that we have the technology to do that.
Mary lost about a month's worth of her memory, but otherwise life is back to normal. And thanks to hypothermia, doctors hope many more patients have the chance to survive. Anna Jackson, NBC4.
Pros and cons. Pros. Patients who were older than 2 days and younger than 18 years of age were randomly assigned to therapeutic hypothermia, target temperature 33 centimeters, or therapeutic normothermia, target therapeutic 36.8. Cons. Among all the patients with data that could be evaluated, the change in the BAPS to score from baseline to 12 months was not significantly different, and 1 year survival was similar.
Welcome to Mission Health System.
Cardiac arrest accounts for about 300,000 deaths every year. At Mission, we use an innovative practice called therapeutic hypothermia. Once the patient's heartbeat is restored, we sedate the patient and cool them down to 91.4 degrees for 24 hours. This temperature management system uses rubber pads that are applied to over 40% of the body. Cold water is then pumped through these pads to cool the body down. By implementing therapeutic hypothermia, we can reduce brain damage caused by cardiac arrest. The survival rate from cardiac arrest is very low. At Mission, we've been able to improve these outcomes. Every life that is saved is the result of an incredible team effort between regional hospitals, EMS services, and Mission Hospital.
Mission Health System.
Conclusion. In comatose children who survived out of hospital cardiac arrest, therapeutic hypothermia has compared with therapeutic normothermia. They then confer a significant benefit in survival with a good functional outcome at 1 year.
It may come as a surprise that hypothermia could actually be a life-saving treatment. In fact, a new body cooling procedure can potentially help cardiac arrest patients return to a normal life. Joining me now is Dr. Shahid Hayat. He's a critical care specialist at the Pulmonary Consultants and Primary Care Group of Orange County. Welcome, Shahid.
Thanks for having me, Larry.
So this is a very interesting topic because cooling has been around for years, is that right?
That's correct. The cooling has been around from a long time ago and treatment options.
So Shahid, how do you cool the body now? What are the modern ways of doing it?
So there are a couple of ways to cool the body. In the emergency department, Larry, we start the patients on IV fluids, which are cold at 4 degrees Celsius, intravenous fluid that cools the body fairly quickly.
Okay.
But then we can have to give a lot of volume, and it's not good. So we into these channels,
okay,
and it provides cooling, a very effective cooling. Now this is applied on the body. It goes on the front, and this part goes in the back. There are 4 of these. One goes on this side, one goes on the other side, and then 2 for the thighs, and provides very effective cooling. That also gets connected to the machine. So the machine knows what temperature the body is, where it wants to be, and provides a very effective and accurate cooling.
So it's pretty sophisticated,
right,
actually.
So it makes
simple.
the job easier.
Yeah. And
Larry, these days use the surface cooling for mild hypothermia.
Okay. So the normal body temperature is 98.6, and you're going to get mild gets it down to about what?
About 92 degrees.
92 degrees.
Right.
And going it down into the 80s, is that more effective?
Studies have been done to see, because if
at a time, or is there kind of a standard time that you cool them?
It is a standard time that we use. After the cooling is started, we keep this on for 24 hours. So the patient's temperature, 92 degrees, is kept for 24 hours.
Very slow.
The warming process is a very tricky process, so we have to go very slow. A lot of complications can happen in the warming process. So we go by 0.25 degrees Celsius. What do the patients feel? A lot of times, especially in the audience, patients may be feeling, if I go through it, will I feel anything? So first of all, the patients are comatose, but we do provide responses to generate heat by shivering. The body wants to keep the temperature higher. And that's a problem for us and for a patient, because patients can feel pain, and cooling process is very important to get down to your cooling temperature as soon as possible.
Now this doesn't save the heart, it doesn't save the lungs, it doesn't save any.
Has recommended to use mild hypothermia, which is called mild therapeutic hypothermia, only for cardiac arrest patients with ventricular fibrillation rhythm or any other rhythm, but not recommended for stroke patients or traumatic, because we are trying to preserve brain function. If somebody has shown that they already have preserved brain function, you can just talk to them, they can follow commands, and they are awake.
During CPR, when patients still do not have a heart rate or a blood pressure, and they still have an
60 minutes.
Okay.
And if they have no neurological function, then mild hypothermia might preserve or even more chances that they might have a meaningful recovery.
That's dramatic. I mean, you think it's like a simple, it's not really simple because the machines.
Thank you for your attention.